Integrated Health Month with the Institute for Community Living. And today's topic is called Decision Support Tools, Optimizing Health Records for Integrated Care. We have our presenters returning today. We have Rosemarie Sultana Cordero, Lisa Chow, who is new with us today, and Jeannie C. And they're all from the Institute for Community Living and will be presenting today. I just want to give you a few pointers. To the right is where we're going to have 3 poll questions today, and on the right is where you will answer those questions. If everyone can participate, that would be really helpful for the presenters and for us to know where you stand with some of the questions being asked. At the end, we will have time for a Q&A. Ashley Fuss will be helping with that. And you can feel free to email us and go to ctacny.com for any further information. Thanks so much, ICL, for being here again today, and we look forward to today's presentation.
Thanks, Kara. We really appreciate CTAC's support in helping us to make Integrated Health Month a reality and hopefully a success. I'm Jeannie C. I'm the Associate Chief Medical Officer at ICL and the VP of Integrated Health. And today we are going to present to you some of our ideas about decision support tools and how we can optimize health records to promote integrated care in clinics and in other programs. This is part of a series where we started out by giving an overview on our concept of behavioral health medical homes, which takes a lot of material from the National Council and the National Association of State Mental Health Program Directors and other sources of thought in this area. And we did a discussion about billing and regulatory challenges as well as information technology challenges at that time. All of our past webinars are posted on the CTAC website if you'd like to have a look as well. And then last week, Rose and Marcia Titus-Prescott and I presented on collaborating for health, disease management for individuals and families, looking at using a self-management model that incorporates psychoeducation and motivational interviewing to help people, children and their families to better self-manage their health and improve outcomes. And next week we have an exciting new webinar on culture, spirituality, and community factors, how we can reach out to address health disparities both in our clinics and our communities, and how to address the barriers to accessing good health care that many of our consumers experience. So hopefully you'll join us for that one, and all of this again will be available on the CTAC website. Now, today we hope to speak with you about the role of health records in integrated care provision. And what we tried to do here at ICL is create a range of decision support tools, tools that make it easy for clinicians who have been trained largely in behavioral health to start to understand how to make decisions about physical health care in their daily practice, and to introduce such a big concept and project as integrated care into a busy clinical practice, so that these tools help them to select evidence-based and best practice interventions in this area. And so what we've tried to do is use our EMR, and before we had our EMR, we used paper records to help clinicians with these decisions. Our goal is to use these tools to facilitate self-management, to stratify risk so that we know which clients are high risk and who needs more care, to help clients make goals that are both person-centered and relevant to their physical health, and to monitor treatment progress. So we hope that by the end of this presentation, you'll be able to think about one action step towards implementation of a decision support tool promoting integrated care at your own agency. Just a word on ICL. I know probably many of you have heard the first few slides of this presentation before if you attended the last 2 presentations. But ICL is a large New York City not-for-profit agency. We have over 100 programs spread mostly throughout Brooklyn, but in all the boroughs except Staten Island. We serve about 10,000 consumers and have the range of services from housing to case management We have ACT, we have the new PROS model, and 3 clinics in downtown in Brooklyn and East New York, as well as shelter-based and school-based programs. And we do have a health home, a New York State health home. We founded in 2001 the Healthcare Choices Medical Clinic to specifically serve people with serious mental illness and developmental disabilities. And in 2011, that became a federally qualified health center. And right now, what we do in our 3 clinics, in our 2 clinics and our PROS program in East New York, is we partner with the FQHC. We subcontract primary care from them so that we can create a real behavioral health medical home in those sites. In addition, just to let you know, the bulk of the consumers that we serve at ICL have schizophrenia, so it's a serious mental illness population. But in our clinics, it's a mixture of general population and SMI. We have a primarily paraprofessional workforce, as I'm sure many agencies do, and so what we have had to do and found very fruitful is investing heavily in therapeutic trainings like motivational interviewing that can help our workforce to manage situations that our clients encounter in a way that is therapeutic, with limited behavioral health experience and training. So what we're really dealing with here is the crisis. The people with serious mental illness, I'm sure many of you have heard, they die an average of 25 years earlier than those in the general population. And that puts them, people with serious mental illness, in the same mortality categories as people in developing countries. So this is something that we have to pay attention to and address. And moreover, 60% of this mortality is due to treatable and preventable medical conditions like heart disease and diabetes. And so that's why we have a real opportunity to make change here. Rough estimates suggest that 40,000 people with SMI die prematurely each year. And so a lot of funding actually has been put into addressing this issue as well. At ICL, and this just gives you an overview of the kinds of things we've talked about in the last couple of webinars. We have followed the chronic care model, that is an evidence-based model that describes how we can improve, at the bottom there, functional and clinical outcomes. And we do that by creating an informed and activated patient and a prepared and proactive practice team. And to support that in the community, we need a health system that provides self-management support, so helps people to be informed and activated. We have to design the delivery system to improve access to care. We provide decision support so that people serving the individuals and families know what to do to provide the best kind of care. And we need clinical information systems that support how we can access information and use information about people. And so at ICL, what we've done is, self-management support we discussed in detail last week in our seminar on disease management. But in terms of delivery system design, what we do is provide medical risk management, which we'll talk about a little bit more today, that helps us to stratify risks and address them. In terms of decision supports, we're going to talk about our clinical pathways that help to bring all these ideas about evidence-based and best care onto the desktop of clinicians. And we're going to talk about how we've integrated our health record, moved towards integration with our health record, because I know if any of you have an electronic medical record, you know that there's no perfect integration right now. But what we've tried to do to improve our clinical information systems. And just to give you a backdrop of our idea about person-centered care, the way we see integrated care is that at the very center of it all is the individual who has goals and values that are very specific to the individual. And those goals and values need to determine how all of the care is provided and what everyone else is on the team is doing. And so if that person's goal is housing, everything else, diabetes care, entitlements, it all falls into place around helping this person achieve their goal of housing. And so we always have to remember that when we talk about any kind of goal, whether it be smoking cessation or stopping using heroin, for instance. Right next to the person served is the care manager or counselor. This person, in the clinics, it's often the therapist, sees the person served more than anybody else, usually weekly, which is far more than the primary care doctor, for instance. And so the therapist or counselor has a really unique role in being able to be the first line of defense, hearing that the person has a new headache or a new rash, and not treating that headache or rash necessarily, but being the person to say, okay, you need to see your PCP. Let me help you go talk to the nurse so we can arrange appropriate care for you. And so the care manager or counselor is at the hub of care. And then the rest of the healthcare team falls into place around this hub, including a nurse care manager that bridges the relationship between the person served and the primary care people. The PCP in this diagram is just slightly outside the circle. That's an artifact of the transition from the PowerPoint slide to WebEx, and certainly, it has been challenging to integrate primary care into the behavioral health model, but that PCP was intended to be inside the circle. Today we're going to focus on one of the health records, one of the things that this whole circle of care is immersed in, and how we can improve that. I'm going to pass it to Elisa Chow, our Director of Outcomes and Evaluation at ICL, to talk a little bit more.
Yes, and we're up for our first poll question. And so the question is, at my clinic, primary care records are 1, part of the clinic chart or electronic health record because these services are provided in our clinic. 2, obtained from another clinic and copies are placed in our chart. Or 3, not part of our chart. You can please take a minute. You could check, click off the response that your clinic is currently, I guess, has. Hi, okay, we have some results back from our first poll question. As you can see, we have the bulk is this one. Oh, I see. Oh, it's B. We have approximately 37% who responded that that primary care records are obtained from another clinic and copies are placed in our chart. And that's followed up by that 7%, which stays as part of the clinic. And last is obtained from, not part of our chart.
Yeah, 4% don't, or I guess that's 1%. 4% said that their primary care records are not part of the chart at all.
Okay, next slide, health records. As Jeannie C. mentioned earlier, we are moving towards integrated health record, and part of this health record is the idea of bringing together primary behavioral health care team, the same information so that we collaboratively work towards together. Part of it provides a structure in regards to the communication. It gives guidance as to the workflow, and also helpfully will provide us prompts as to when information is needed at that time. Now, what goes into the electronic health records, we're looking at specific decision support tools. And so we come together and decide on, well, what decision support tools are needed? And that can help engage and guide behavioral health staff in integrating best practices into existing workflow. Facilitate decision-making in real time. Receiving feedback from the person-centered multidisciplinary team. Support health goal settings for person served. and also making integrated part of the routine and culture. So we looked at, and these are the decision support tools that we are going to be talking a little bit more detail about today. And there are 6 decision support tools. The first one is the Healthy Living Clinical Pathways. The second is the health risk screening. The third is Healthy Living Questions. We also have the Healthy Living Self-Management tools, also Physical Health Treatment Goal Planner, and the prescriber's documentation. We're really going to be focusing more so on the first 3, really. In fact, yes, in more detail. And so we're going to move towards the Healthy Living Clinical Pathway with Rosemary.
Actually, I'll be taking this one.
Sorry, Jeannie.
No problem. All right. So the first tool that Elisa mentioned was the clinical pathway, and this is, you're not expected obviously to read all of this clinical pathway, but the idea here is that we've selected from all of the possible interventions that a person can use when they are a behavioral health therapist in a clinic to address physical health concerns, and we've taken what we believe is best practice and evidence-based and put it into the pathway, so that when we do a training, we lay this pathway out for folks so that they can understand, what is expected of them in terms of assessment, preparation for collaboration, treatment, and outcomes measurement. And so this is the skinny for them, and we're going to break it down because obviously it right now looks pretty daunting. The first section, though, involves diagnosis and risk assessment. And if you look in the top left-hand corner, at the beginning of any episode of care, there's a health risk screening that's done at the intake by a behavioral health clinician for the person served. And based on that health risk screening, if there are flagged responses, it triggers a nursing review process for higher risk. And if there's high risk, then there's at least monthly multidisciplinary review of that high risk case. If it is lower risk, then we go through the usual pathway of making sure there's an annual physical exam done and obtained for the chart. And if there isn't one, then there's a referral to a primary care provider, which we thankfully now have on site at our clinics. Then, in terms of preparation for collaboration, the focus is on making sure that the person has a complete healthcare team to support them, just like we showed in that circle of person-centered care, a complete healthcare team to support them on their journey to recovery. So here's another poll, and this one says, at your clinic, how is physical health information assessed? Is it by psychiatrists and or nurses only? By social work staff in addition to psychiatrists and or nurses, or it is not assessed by our staff? So we're just curious to know, just like, with the EHRs, we wanted to know how other people are obtaining primary care records. I think we've experienced, and many of our colleagues have experienced as well, that it's very hard to get a physical exam back from a lot of primary care doctors, and so often, even though it's a requirement in the clinic, it's just something we don't often have. And having on-site primary care has definitely helped with that, but I know people have found different solutions to that problem. And here, in this situation too, we believe that full integration involves having, as I showed earlier, the behavioral health clinician involved in physical health care, not just referring to psychiatrists and nurses, and often psychiatrists don't feel that physical health care is part of their, some psychiatrists do not feel that physical health care is part of their domain as well. And so, changing the culture so that everybody's involved in behavioral health care and everybody's involved in physical health care is one of the things we've tried to do. Well, we have the poll results now, and actually only a few people answered, but of the people that answered, primarily people said that physical health information is assessed by both social work staff and psychiatrists and or nurses. So what we do with our health risk screening is that the behavioral health staff administers it at intake, as I said. It's a self-report style screening, but it's the behavioral health clinician helps to interpret it. And the way we've set it up is that there are yes-no questions that flag potential risk and prompt whether a nurse is going to review that chart and then decide whether or not to meet with the patient and whether primary care follow-up is needed. So, and then as I said, these clients will be discussed at a monthly multidisciplinary medical risk management meeting. That's a mouthful, but to determine whether that client is receiving appropriate intervention to address their level of medical risk. And so this just gives you a sense of what the form looks like. On the right-hand column in the form, and this, of course, this was our paper form before we went to an electronic medical record. On the right side of the form, you see that if you answered, for instance, do you see a primary care provider, is the first question, and if you answered no, that flags you for nursing review. So if there are any responses in the right-hand column, then the person will be, this chart will be reviewed by a nurse, and the nurse may decide to meet with the person. Based on the nurse's assessment, the person will be assigned to either a high-risk category or not. And the way we determine whether someone is at high risk, and obviously this is a complex decision to make, but the rough guideline that we give to our nurse care managers is that if there is non-adherence, evidence of non-adherence to medical appointments or prescribed treatments, if there are new symptoms that have not yet been addressed, or if there's a chronic condition that requires a higher level of care that has not yet been obtained, such as someone needing oxygen, for instance, that person is at higher risk. Everybody else is at low risk, but there are still interventions, preventive interventions provided to the low risk folks. And so that is the skinny on how we provide risk management. And so basically, if someone ends up in the high-risk category, then the team provides closer monitoring and multidisciplinary discussion around that person's case. I pass the time to Rose Sultana Cordero, who's our clinical coordinator of integrated health, to talk a little bit more about preparation for treatment and treatment.
Okay, I'm going to talk about the preparation for treatment and treatment portion of the clinical pathways that Jeannie introduced in this webinar. We have some great decision support tools here. Unfortunately, the webinar doesn't do justice to what you're seeing on the screen, so if you would like more information, we are offering a learning collaborative. We invite providers in the New York State, New York City area to join us, where we can talk more about these decision support tools. They started out as on paper, but eased their way into our electronic health record system. So it's a conversation that we could have with providers that are interested in providing more integrated health services at their clinic. So this is the preparation for treatment and treatment portion of the clinical pathways. And this, as Jeannie mentioned, is available to case managers, clinicians on their desktop in their clinician toolkit. And it provides a guide for preparing for treatment, providing treatment with a focus on keeping it very client-centered. Because when we say the word decision support, it's not, we don't want to give the impression that the clinician or the case manager is making all the decisions for the consumer, but these are tools to engage the consumer around identifying health goals so that the case manager or clinician can support them in reaching these health goals through action steps. Sorry, next slide. Thank you. Okay, so one of the tools that ICL created is the Healthy Living Questionnaire. It started out on paper and was administered by case managers and clinicians to their clients every 3 or 4 months. And what this was a questionnaire that tried to assess clients' health behaviors and their level of self-managing their health or any health conditions that they were challenged with at the time. It also helped to assess use of emergency room and inpatient services. As I mentioned, it started out on paper, and it was a great engagement tool to kind of get a sense of where a client was at as far as understanding their health behaviors, wanting to change their health behaviors, and also their level of knowledge in trying to self-manage their health. All right, next slide. Okay, again, this slide doesn't do justice to the Healthy Living Questionnaire. It is, again, questions that are trying to target where clients are on health behavior. In entering this questionnaire in our electronic records, it coincides with treatment and service plans that our case managers and clinicians complete. So again, it's a great time to kind of check in to see where people are at in managing their health. It's a way to engage clients and consumers around possibly identifying a health goal that can be entered into their treatment or service plans. And it's a great way of following up if they have identified a health goal to see where they're at in achieving that goal. Thank you. So these are some tools that we mentioned in our last webinar in disease self-management. I'm going to mention them again quickly. Again, if you would like more information on these self-management support tools, please contact us at the email address that is at CTAC, and also if you could please join us in our Learning Collaborative, because we're going to talk more about these self-management tools and how they can be used. Our main self-management tools are in the form of workbooks that are on a 3rd to 5th grade reading level. Both the case manager and the consumer use the same materials. Their foundation is in motivational interviewing techniques and skills. Built into these workbooks are action step pages that allow clients to identify goals as well as action steps in the area of health and self-management. And again, all of these tools are also on the desktop available for ICL staff to access. This is a sample of the areas that we hit in the action step page. These pages are at the end of each of the Healthy Living modules. We also have a workbook on diabetes that also follow the same format. It's motivational interviewing based, and it allows at the end of each chapter for clients to identify health goals as well as the action steps. So we try to keep it very concrete. So who, what, when, where, and how of your health goal. Who's going to help you remember this health goal? What's the starting date? What are some small steps that you think are doable for you to work on as far as achieving the overall big goal of self-managing your health? So we come to our third polling question, and this is in reference to treatment plans. So poll question number 3 is, do your treatment plans incorporate physical health goals? Yes or not yet? And we're going to give everyone a few moments to answer this poll question. Okay, we're still waiting for some answers to our poll questions, and they're up. So it looks like the majority of you are entering physical health goals within your treatment plans, and that's great. So these tools are really great supports in helping clients identify those goals and action steps towards those goals. So I hope the people not yet might want to join us on our Learning Collaborative and get more of a feel for our decision support tools. Okay, so another tool that we have created is the Physical Health Goal Planner. And what this, it started out again on paper, but has entered into our electronic health records. And it helps case managers, clinicians to identify health goals, and it provides some narratives that consumers might want to think about in steps towards their health goals. It's objects that are available within our electronic health records, so it's a very smooth transition. It helps as a case manager is sitting with a clinician. The narratives are there that they can suggest, so that it helps clients to kind of concretely identify what is the health goal, and also what are the steps that they might consider taking as far as achieving those goals. This is a sample of what it looks like within our electronic records. And again, it coincides with the time that case managers would be completing treatment and service plans. So it's a very easy flow. It allows narratives for both the case manager to suggest and for clients to consider, and it helps to identify those goals, especially if they're being incorporated within a treatment plan. This is what it looks like on paper. It was provided on a laminated card, with one side having the problem and goal tiers, and the other side having the clinical pathways, which we presented earlier in the webinar. But again, it was an easy tool to use and present and engage a client around. And it has general health areas that people may want to consider in self-managing their health, like nutrition, physical activity. And it also had disease-specific narratives that clients might want to consider if they're challenged with specific medical conditions like diabetes, hypertension, or Hep C.
So going back to the clinical pathway, the last part of this pathway is the outcome section. So again, here is just a quick overview as to, whether, a quick check-in as to whether the client has improved in regards to the physical health goals that they have put forth, or they're not improved, and which directions and which direction to take, or which approaches to take moving on. So decisions for the electronic health record. We use, ICL uses the Anasazi program, the electronic health record, and it kind of helps us track medical conditions, vital signs, and medications. So that it can be easily looked at a quarterly basis and easily extracted. We also look at the ICL's psychiatric progress notes, which prompts for metabolic monitoring and non-psychotropic medication use. Other things that we have put into place also is the e-prescribing system, which provides alerts related to drug interactions and risk in pregnancy. What's not integrated as yet, but we do plan in the near horizon, is our lab results, and to possibly have that integrated into our electronic health record, and that's on our wish list. Future direction. So moving forward, we are continuing to evolve, and we're still looking at how to better integrate all this information obtained for physical exams. Right now, physical exams are coming in physical copies, and much of that information is not has to be entered into electronic health records. So again, one day we're looking at possible electronic upload into our electronic health record.
Yeah. One thing that so this is Jeannie. One thing that we have made the decision to do in our program, which I know that different clinics who have primary care on site have made different decisions around this, is we have our primary care doctor enter the physical exam information directly into our behavioral health record. And the behavioral health record is not designed, the one that we have anyway, is not designed to make that easy. It doesn't make use of the data to, for instance, populate other fields in the record. But we did make a decision to do that rather than to have two electronic records, you know, the one that is more primary care friendly and the one that is more behavioral health friendly, because we really do feel that having an integrated health record helps to coordinate care in our programs. But that's still something we struggle with.
Exactly, and then also we need to look forward into regards to the information that we're going to be getting out of the REALS, which is the Regional Health Information Organization, which is live information, and how to have that incorporated into an electronic health record and what to do with that information. Also, you know, looking at integrated multi-agency treatment plans, and there's also intra-agency treatment plans. You know, we have a number of clients, for example, who are involved in multiple ICL programs that their notes and their treatment plans are not really integrated. It's not integrated at the present time, so we still continue to struggle with that. So in some sense, our advanced thinking has not caught up with technology yet. Yeah, next. So some take-home points, okay, the three main take-home points. One of them is that integrating your physical health and behavioral health requires significant workflow change. It is not an easy and overnight incident. It does require a lot of buy-in from all behavioral health staff and can be challenging because, you know, integration may, you know, increase the responsibilities. But to help reduce that burden and make integration as part of the routine and culture, we look at streamlining tools and prompts that can help the clinician or case manager, program staff, to make a smoother transition as we work towards integrated health.
So thanks, everyone, and for your time today. I know, you know, lunch is a precious part of your day, and so thank you for spending it with us. I hope, you know, we've done just a brief survey of all of the different kinds of tools we use at ICL, but the idea is that, you know, making this transition to integrated care is not easy, and especially for a behavioral health workforce. And now we actually have all these integrated health interns, social work interns with us right now who are learning about physical health care. But I think much of our workforce is not trained in this, and so to provide tools that point out what is evidence-based and best practice, that help to easily stratify risk based on, you know, clear responses, that help people to guide consumers to make person-centered physical health goals. These are some of the ways that we've tried to integrate physical health care into the behavioral health world in the most painless and most useful way that we could think of. And I know many agencies have been very creative in this area as well. But as Rose said, one thing we're hoping to do is create a learning collaborative for our learning as well as, you know, hopefully everyone else's, and to share our materials and see if they can be helpful to other agencies as well, and to be able to, you know, share our model with other folks. And so if you're interested in participating, please do contact Rose at rsultanacordero@iclinc.net, which is in orange on the left-hand corner there. And you can visit our behavioral health medical homes page, where a lot of the information we talked about is displayed at iclinc.org. So now we're happy to take any questions or discuss further. If other agencies have things that they do that they'd like to share with folks, we'd be really interested to hear that as well.
So hi everyone. Thank you so much for all of our attendees for joining today's webinar. And I want to give a really big thank you to Rose, Jeannie, and Elisa from ICL. If anyone has any questions, please chat them into the box to all panelists or to myself, Ashley Fuss, and we will get those questions answered. So I'm going to give you guys a few minutes to do so. Okay, so ICL team, I do have a question for you. The question is, if a clinic does not have an internist or a pediatrician, how do you monitor medical progress with clients since outside the medical providers are not easy to reach?
Yes, and this has been an age-old challenge for us too. So what we do is, I guess a few things. We use the health risk screening, and so that starts off the conversation about health. What is the baseline in terms of primary care access, adherence to appointments, what kinds of screenings have people had, what treatments are they receiving, are they, what are their physical health, physical activity and dietary habits like. At intake and every 3 months, our psychiatrists are also required to do weights and blood pressures for folks, and so that is one measure that we have on an ongoing basis. But after, at every quarterly treatment plan review, I think as Rose introduced, we have a healthy living questionnaire, and it includes items on both a self-reported health and adherence, but also on ER and hospital utilization. And so those are measures we use to monitor health without outside of what we get from physical from the primary care documentation. We recently introduced nursing using Part 599, which we discussed more in our first webinar. Using Part 599, and some grant funding as well, but Part 599 does provide for this. We introduced nurse care management, and so the nurses help to monitor health conditions for our clients at highest risk. Now that we do have primary care on site, we're able to, do a little bit more. Before, it was really seeking documentation and liaison with outside primary care providers, as I think many agencies are doing at this point. I hope that's clear, but if the person who answered that question wants to, clarify anything, please let me know.
Thank you, Jeannie. So I'm just going to wait a few more seconds, and if anyone has any more questions, please chat them into the chat box. Okay, so it looks like we have no more questions, so I think we're going to wrap up. To everyone on the line, just a reminder of a few upcoming CTAC events. So on October 23rd, we'll have the last Integrated Health webinar presented by ICL, which is called Culture, Spirituality, and Community Reaching Out to Address Health Disparities. On November 8th, we will have Part 2 of our Suicide Prevention webinar presented by Dr. Aruna Jha. And again, our website is www.ctacny.com, so please visit our website and check out the resources we have there. The slides and the recording from today's webinar will also be posted on there shortly. So with that, I just want to thank everyone again, especially a big thanks to ICL for presenting us with this really useful information about how you guys have integrated physical health into your clinics. And with that, I will say goodbye and thank you, and have a good day, everyone.
Thank you.